So the first thing that you have to realize is there's a lot of uncertainty when it comes to estimating fetal weight. And there's basically three methods. One is to take measurements with ultrasound, and then the machine calculates an estimated fetal weight based on the measurements you take. Um, there's clinical examination. You lay your hands on the belly and you kind of see what the baby feels like, and you make an estimate that way. And then there's also a maternal estimate. So for people that have given birth previously, sometimes they'll have a sense this baby feels similar, smaller, bigger, and all of those three methods have been found to be similarly inaccurate. Um, they're always estimates, and there's a lot of room for us to be surprised at the time of birth of the baby. So um, when it comes to ultrasound, which is I think in modern practice, technology in a lot of ways has replaced what used to be done clinically. So very often, ultrasound is used, and it'll commonly will be said, this baby's looking big, and two things may happen. One is we should induce labor before the baby gets any bigger. um, and so um, what you end up seeing in practices that function this way is people will be told it looks like this baby's getting close to 10 pounds. um, Maybe we should even do a C-section. The
Mhm.
laboring and giving birth would be a little bit too dangerous, and the C-section is performed, and out comes an 8-pound baby. Like it's just dramatically different than what the estimate was. um, and I think that's fine if there's transparency in the beginning, that look, there's a lot of uncertainty here. Ultrasounds are known to not be very accurate. The size of the baby may be very different than what this estimate says, but it's all we got. And you make your decisions based on best available data. I think that's fine. But a lot of times there's very poor transparency about this, and there's a much more coercive, like, look, this is just going to be a very risky, childbirth, and this is going to be the safest way to go, kind of implying that there's a lot more certainty than what is truly there. Um,
Yeah.
so the reality is, um, there is such a thing as birth trauma. There are there are births that happen where injuries occur that may be related to the size of the baby, and this could include both the the baby, with fractures and nerve injuries and things like that. These are not things that are impossible. They are things that happen. And there also can be, significant injuries to the birthing mothers, or birthing people with, like big, pelvic injuries or vaginal tears, particularly, tears that extend down into the anus or rectum. And these can have, a lot of symptoms and a lot of consequences down the line. So these births, they do happen, and I think it can inspire a lot of fear in the providers of care. And when they see a case like that, they don't ever want to see another case. And you start to think,
Right.
how can I avoid these kinds of incidents in the future? And one of the thoughts that made it occur to you is, well, let's induce labor a little bit earlier, or let's do a C-section. So it's very logical thoughts, and they can come from a very altruistic place, from people who just want to prevent bad outcomes from happening. Unfortunately, there are studies that have looked at the idea of inducing labor for suspected big baby, and it turns out they have never really been shown to reduce the risk of birth trauma. So
Mm.
if you if you take whatever population, and there's a certain percentage of cases that result in birth trauma, if you take the practice of inducing labor, um, it actually does not reduce that percentage. So inducing labor for a suspected big baby appears to be not an effective maneuver. And in fact, it says as much in published ACOG guidelines that that's not
Mm.
an effective intervention. And despite that fact, that practice is very, very common, in the community. Um, and why is it that it's not effective? Well, there may be a couple of things. One is that um, when you look at fetal growth patterns, um, the fetus does not grow along a straight line where the growth is the same, every week. There's more of like an S-shaped curve where there's, slow growth in the first and second trimesters, and it really kind of explodes in the third trimester. And you have this
Mm.
acceleration, you have this rapid growth, and then you get to the last weeks of pregnancy, and then it kind of the curve sort of flattens off, and growth is much slower in the last weeks of pregnancy. So
Mm.
let's say somebody wants to induce at 40 weeks because they're concerned about the size of the baby. Well, if you think about it, 1 week later, that baby is going to be more or less the same size. It's not dramatically different. So the idea that we're going to be fine now at whatever weight we are, but 200 grams later, a week down the road, this is going to be a traumatic birth. Like it's very unlikely that you are, right about to cross that threshold at the exact gestational age, where you are in the pregnancy. Um, the other thing is that it may be that pregnancies that are destined to have a traumatic birth, maybe they cross that line at 37 or 36 or 35 weeks where you would not be inducing labor. So the
Yeah.
gestational age where you would think about it, 39, 40, 41, maybe it's just, it's too late for those pregnancies. Whatever the reason is, there's no evidence that inducing labor for a big baby, um, is helpful. Um,
Mm.
for cesarean section, it gets to the same sort of dynamic that we talked about with inducing it for late term pregnancies. There will be births where some kind of trauma is going to happen during the birth, either to the baby or to the mother. And if you decide to deliver by cesarean section, you may avoid that birth trauma. The problem is it is impossible to know which pregnancies are destined to end in a traumatic birth. There's no way of knowing that. And if you use a certain cutoff of fetal weight, and you say, well, above a certain weight, we're going to recommend a cesarean section. Um, you can do that, and you are going to prevent some traumatic births. The problem is, um, a lot of the babies that you have deemed are above a certain weight when they're actually born are not going to be above that weight.
Right.
So you are actually doing your interventions on babies that don't meet the criterion that you're concerned about. Even if the ultrasound was perfectly accurate and you could tell to the gram what the exact weight of the baby is, you still don't know which ones are going to have a traumatic birth. Some women give birth to a 10-pound baby with no difficulty whatsoever. Some women give birth to an 11-pound baby with, no difficulty whatsoever. I shouldn't say no difficulty whatsoever. Maybe I should say
It's hard work.
without birth trauma, right?
Yes.
Birth is tough, um, but it'll be a healthy, normal childbirth without traumatic injury to mother or baby. So just because the baby's above a certain size, you still don't know if this is a birth that's going to end in birth trauma, and in fact, the majority are not. It's really a very
Mm.
small percentage that will. And so if you adopt a policy uh, of above a certain weight, you're just gonna deliver by cesarean section. You're gonna do cesarean section on a very large number of pregnancies that would have done fine had you not done the cesarean section. And in order to prevent that one case of birth trauma, you're going to do hundreds or maybe even in the thousands of cesarean sections. And so then you got to ask the question, well, how much harm are we doing with that, huge number of
Yes.
cesarean sections? So because of that trade-off and all of the uncertainties there, if you look at our national guidelines, the American College of OBGYN says if the estimated fetal weight is above 5 kilos, which I think is about 9 pounds, 13 ounces. I had to calculate that out. I always forget. But if you're above 5 kilos or in a diabetic pregnancy above 4.5 kilos, what they say is it's reasonable to have a conversation about cesarean section. They don't say that you must do it. They say that it's reasonable to have this conversation. And then, people can decide how they feel about it. People who are maybe more afraid of the risk of traumatic birth will opt for cesarean section. Maybe people who are more afraid of the cesarean section would opt to, let's do a try. I understand the risk you're telling me, but why don't we try for vaginal birth and, and we'll see how it goes. Um, so that's what the guidelines say. But again, um, uh, if you think about that, if you had an estimated fetal weight that said, 4.9 kilos, according to the guidelines, you wouldn't even discuss cesarean section. It wouldn't be reasonable to even discuss it. But I guarantee you the discussion is being held, and
Yeah.
there were many practitioners that would probably even recommend a cesarean section in that scenario. And some providers will even insist on or demand a cesarean section. Um,
Mhm.
and if somebody doesn't want it and they really want to try to labor, the provider may even discharge them from their practice, or just really try to coerce them into cesarean section through other ways. But that implies a lot more certainty than what there really is, or a lot more risk associated with the labor than what there really is.